sure that this becomes a chance to ask a lot of questions, because this is a unique opportunity for us. So Dr. Wang, as most people know, is a professor and chair of medicine at UT Southwestern Medical Center. He has strong ties to the Northeast. He has went to medical school at the Harvard Medical School. He completed a residency in internal medicine and fellowship at Mass Gen. He joined UT Southwestern in 2020 while I was wrapping up my fellowship. So although we overlapped because of the pandemic, never got a chance to personally meet. Before that, he was the director of the Division of Cardiovascular Medicine at Vanderbilt. He's a fellow of the American College of Cardiology and American Heart Association, but also an elected member of the ASCI, the Association of University Cardiologists, and is the immediate past president of the Association of Professors of Cardiology. Dr. Wang has had a storied career in investigative clinical medicine, spanning clinical and translational domains in preclinical cardiovascular disease, obesity, and metabolism. He's had successful, long-standing success with NIH funding and has nearly 5 pending or awarded patents. His work's been published in the New England Journal of Medicine, JAMA, and everywhere that we can think of. And then he's been consistently recognized as a highly cited researcher from Thomson Reuters. So with that introduction, I'm going to hand it over to Dr. Wang, who will present on will the future of cardiovascular prevention be more precise or less? Thank you.
Great. Thanks so much, Dr. Kara. Really appreciate the invitation to speak today, and great to see friends and former colleagues like yourself and Dr. Velasquez and Dr. Churchwell and many others. As mentioned, I'm from the Northeast. I always value the chance to visit places in the Northeast, unfortunately this time virtually, hopefully in the near future in person. So today I just want to talk about a topic that has been of interest of mine really since I was a fellow at the Framingham Heart Study, where of course one of the major areas of focus of that long-running epidemiologic study has been prevention of cardiovascular disease. And I want to put it in the context of the current era of precision and precision medicine and relate the two. So let me just figure out how to. These are my disclosures. As Rohan mentioned, I do biomarker work, and so a lot of these patents are related to biomarkers that we have studied. And so really the reason for putting this talk in the context that I'm placing it is the fact that I think we would most widely recognize and acknowledge that we're in an era where precision medicine is emphasized. And that's really actually been going on for several decades now. The Time magazine article in the middle of the screen is actually back from 2012. So the concept has been around a long time, and different labels have been used, including personalized medicine, but currently precision medicine is the most widely accepted one. There are a number of different definitions of precision medicine, but I actually like the advertisement on the right from Sloan Kettering, which I think captures it well, which is really the concept that cure for disease will be personalized to individuals and their characteristics, and there won't be a one-size-fits-all. And so obviously this seems like a relatively non-controversial concept and certainly has been applied to cancer. The question is, can we apply it to cardiovascular disease? And so as a brief overview of the talk, I want to talk about 3 topics. To have precise medicine, you need to identify people who are going to get disease. And so the first 2 things I'm going to talk about are biomarkers of preclinical cardiovascular disease, and then biomarker discovery in the second part. But then you also have to do something about it. And so the last part of the talk goes into sort of just some broader thoughts about how to deliver preventive therapies in 2022. And so to motivate it, I just want to talk briefly about a case scenario. Suppose you're a cardiologist in the year 2000, and you have 3 patients in your practice. One is a 32-year-old physically active man. Another is a 50-year-old man who's overweight and hypertensive, but doesn't have overt cardiovascular disease. And the third is a 59-year-old man who has well-established cardiovascular disease. He smokes, has had 5 MIs and a cabbage, and actually continues to have these bad habits, including smoking. And so the question is, if you have these 3 patients in your practice in the year 2000, and you were asked, over the next 5 years, which of these patients is likely to have a fatal cardiovascular event, I won't put the question out there, but almost certainly everyone in the audience would say the man on the right, the 59-year-old man who's already had 5 MIs. The reason I mentioned this example, though, is that this is an actual, these are actual patients. And so in the year 2000, the first gentleman, Darryl Kyle, was a professional baseball player. He was a pitcher for the St. Louis Cardinals, and he had just finished a 20-win season. The man in the middle, Tim Russert, was the long-running host of Meet the Press. And the man on the right, Dick Cheney, was about to start his 2 terms as the vice president. Most of us will recall at least what happened with some of these individuals. Mr. Kyle died 2 years later in his hotel room, sudden cardiac death, and the autopsy was found to have a massive MI and occluded left anterior descending artery. Tim Russert died 6 years later of an MI. Interestingly, he died about a week after having a negative stress test. And former Vice President Cheney is retired and active now more than 20 years later. Now, would qualify that in that he no longer has his native heart. He was transplanted several years after he retired from government, but even before that time had no major cardiovascular events. And so the reason for highlighting these particular patients, and obviously this is somewhat anecdotal, but is to emphasize the point that prediction of cardiovascular disease is hard, especially hard cardiovascular events. And I would argue that even if it were the year 2020, and these were the patients, that based on the tools that we have today, our ability to actually predict what would have happened to these individuals isn't actually a whole lot better than it was in the year 2000. And while these are, again, anecdotal examples, they do capture a broader point, which is that many people who get heart disease would be viewed as low to intermediate risk. And I put low risk in quotes because, of course, risk is a continuum. But again, based on conventional risk factors as shown in this pie chart, the majority of individuals, over 50%, have either 0 or only 1 traditional risk factor of cardiovascular disease by the time they have a cardiovascular event. These are old data, but data that still apply in the present day. And so as a result of this understanding and this recognition, there have been many efforts over the years, really decades, to find other markers for cardiovascular disease above and beyond the conventional cardiovascular risk factors. 2 of the frequently studied biomarkers are shown here. Of course, probably the prototypical non-traditional risk factor cardiovascular disease, C-reactive protein, shown on the left. This is one of the early studies from Paul Ritker in the Physician's Health Study, showing that in the Physician's Health Study, higher levels of CRP were associated with a higher relative risk of myocardial infarction. And that was true, especially for people who weren't taking aspirin. When I was a fellow at Framingham, we were interested in other biomarkers. The study on the right shows a study with B-type natriuretic peptide, which was just being introduced to clinical practice at that point, showing that individuals with higher levels of BNP, although still within the non-heart failure range, had a higher risk of cardiovascular events and mortality over many years of follow-up. As a result of these data, a couple of years later in Framingham, we did a larger study looking at a bunch of biomarkers simultaneously, figuring that if 1 or 2 biomarkers were helpful, 10 biomarkers may be even more helpful. And we came up with a somewhat surprising result that even if you combine 10 of the frequently studied cardiovascular biomarkers and looked at how well it predicted future cardiovascular events in a relatively healthy ambulatory cohort, that while each of the biomarkers was statistically associated with cardiovascular events, even collectively, they didn't serve to move the area under the curve by a substantial amount. The area under the curve with conventional Framingham risk factors is about 0.7 to 0.75, and the addition of the biomarkers, again, only moves it slightly. And what we've generally found, and what most studies find, is the gains in discrimination as measured by the statistical area under the curve, even with large numbers of biomarkers, are modest. Although for individuals near a threshold, if you're using categories of risk, may get reclassified from one category to the other, because even these small movements may move them across the threshold of risk. But again, overall, I think compared with some of the early enthusiasm about these conventional biomarkers, the findings when you look at rigorous measures of risk prediction are relatively modest. One recent and natural question is whether genetic information can help, particularly sort of apropos the question of precision medicine. So shown on the left, of course, is what's available to consumers. You can go on Amazon and order a 23andMe test and get genotypic data across the genome for a number of common diseases, including cardiovascular disease. A well-cited study is shown on the right, as reported in the New York Times, done by Seth Kathiresan, Amit Kara, and their group at the Broad Institute, looking at a genome-wide panel of the polygenic risk score for predicting cardiovascular risk. And they found that using the polygenic risk scores and applying it to large biobank data like the UK Biobank, that the polygenic risk scores stratified people along quantiles of cardiovascular risk. And in fact, individuals in the top several percentile of polygenic risk score really seem to have a markedly higher relative risk for coronary artery disease compared to individuals at lower quantiles of risk. And so this again has served to reignite some excitement around biomarkers, this time genetic biomarkers for predicting cardiovascular risk. But when you apply these new risk markers, these genetic risk markers to traditional epidemiologic cohorts, you get really the same findings that you get with soluble biomarkers. And so this is a study that I did with Jonathan Mosley while I was at Vanderbilt, looking at the application of the Kathiresan-Kara polygenic risk score to two large US cohorts, the ERIC study and the MESA study. And what we found was that by itself, the polygenic risk score only modestly increased the C statistic from 0.5 to about 0.55, 0.559. That single change alone was much less than you would find with the traditional pooled cohort equation. When you added them all together, it was slightly better than any individual one. But again, the difference between the pooled cohort equation alone and the pooled cohort equation adding the polygenic risk score was really quite modest, again, in the range of what you would find with soluble markers. In fact, when you look at other measures like reclassification, you would find even more modest changes. And so this looks at the results in ERIC and MESA using the two categories of risk in the new guidelines, the less than or greater than 7.5% 10-year risk, showing that you actually get non-significant reclassification with the use of polygenic risk score in either of these two cohorts. These are unpublished data done also with Jonathan Mosley and with Aaron Aday, a vascular medicine cardiologist at Vanderbilt, showing the point that I implied earlier, which is that the polygenic risk score really is no better than commonly available soluble biomarkers. And so again, if you look at the pooled cohort equation, this time in ERIC, you get a C statistic of about 0.71. If you add the polygenic risk score, it goes up to about 0.72. Instead, if you add HSCRP, a single widely available and inexpensive biomarker, you get about the same bump. If you add them all together, again, you get a slightly higher bump. But again, the contribution to that increment from the polygenic risk score is really not all that substantial. So I think at this point, everyone in the field who is interested in prevention would acknowledge that probably our best non-invasive predictor of future cardiovascular risk, especially in a primary prevention setting, is coronary calcium. And there have been a number of studies over the years. The one I showed here is parochial. It's the data from the Dallas heart study, published by Amit Kara and colleagues at UT Southwestern, showing really the striking increase in relative risk that you get with individuals who have CAC scores above 100 and further than that. And unlike some of the soluble biomarkers, the CAC score in most studies actually translates into an appreciable increase in the C statistic, and also a relatively large net reclassification index. Lastly, James DeLemos, also at UT Southwestern and working with data from the Dallas Heart Study, and his colleagues have shown that if you combine all these various biomarkers, the soluble biomarkers, CRP, BNP, high sensitivity troponin, if you add in CAC, and you also include a conventional measure, ECG, LVH, that the cumulative result of these tests is higher than any individual test alone. Again, not particularly surprising, but the study that James and colleagues has done has helped to quantify it, again, with a C statistic in the 0.05 range, but a NRI that's larger than you would get with individual biomarkers. With a caveat that most of this, again, is probably driven by the CAC as opposed to the individual biomarkers, but the soluble biomarkers do add a little bit of this. So if I were to summarize, at least sort of in my mind, where we are with newer tests for cardiovascular disease above and beyond traditional risk factors, this is what I would say. I would say with soluble biomarkers, the advantage of soluble biomarkers is you can characterize any stage of disease, be primary prevention, secondary prevention, early disease, late disease. It's a little bit agnostic to that. The disadvantage is that compared to other modalities, the accuracy, sensitivity, and specificity are relatively low. It is, however, inexpensive to measure most soluble biomarkers, very easy to get. A final aspect to consider is the specificity for cardiovascular disease, and we'd have to acknowledge that most of these biomarkers can be altered by other factors as well as cardiovascular risk. Coronary calcium in the middle, I would say, has the potential disadvantage that you can only capture disease at a later stage. At the early stage of non-calcified plaque, you wouldn't really expect the CAC measurement to really add much information. That said, and as I mentioned, the accuracy probably is the highest of the non-invasive tests. The costs are not as high as they used to be and coming down. And it is fairly easy to get, but we can't ignore the fact that there is radiation involved, and especially if it's used sequentially or serially, the potential risk of cumulative radiation has to be taken into account. The last and the most recent are the polygenic risk scores, and there is a lot of excitement about this. One of the reasons to be excited is that you can measure it at any age. You can literally take a teenager and measure the polygenic risk score, and you're capturing potentially a lifetime of cardiovascular risk. So that's attractive. The accuracy is still controversial. At least in our hands and in some of the cohorts we've looked at, the accuracy is really no better than that with the biomarkers. The cost is still relatively high, but presumably that will go down over time. The ease is getting easier. But one of the disadvantages is really linked and related to one of its advantages, that because it's present throughout your lifetime, it also doesn't change. And so it can't really be used as a marker of response to therapy or change in therapy. And potential things that individuals do to improve their therapy will not be reflected in the polygenic risk score. So, because of what I've just described, really many groups have been working on this idea of how do you find new biomarkers for cardiovascular disease, acknowledging that the ones we currently have are really only moderately effective at best. And so as I think about this as a clinician and clinical investigator, I think there's a distinction from the oncology literature, which is very useful to keep in mind, which is the difference between prognostic biomarkers and predictive biomarkers. Because when we study biomarkers and evaluate them, we should take into account, what exactly we think that the beneficial feature of those biomarkers is. In epidemiologic terms, a prognostic biomarker is something that's associated with outcomes. It's almost the sort of the necessary feature of every biomarker, that it has to be associated with the outcome that you care about. Predictive biomarkers are biomarkers that are associated with the outcome, but there's also an interaction with therapy. And this is illustrated on this slide. And so if you look at the graph on the left, this is what you get with a prognostic biomarker, but one that is not necessarily predictive. The blue line shows individuals with one level of that biomarker. The red line shows individuals with another level of the biomarker. And as you can see, individuals with the blue level have a different survival experience compared to individuals in the red. And so that, again, it meets the essential characteristic of a prognostic biomarker. But then if you look at whether people are on or off treatment, shown by whether the line is solid or dashed, the relative risk reduction for treatment is the same whether you're blue or you're red. And so the level of the biomarker doesn't predict any type of difference in relative risk reduction. That's in contrast to the individuals on the right with a prognostic and predictive biomarker. So that the individuals in the red don't derive benefit from therapy, where individuals in the blue do derive benefit from therapy. And so why is this relevant and how does it relate to cardiovascular disease? I would argue that most of the newer biomarkers that we're looking at least based on the present data, are mostly prognostic. We don't really have a lot of evidence that they're predictive. And so an example would be CAC or the polygenic risk score. One of the reasons they're prognostic and not predictive is that they capture either multiple factors that contribute to cardiovascular disease, or they reflect, as in the case of CAC, an epiphenomena or an end, sort of a common end pathway or common finding in cardiovascular disease, but they don't necessarily flag a specific pathology. And that, that could be true of polygenic risk score as well. By definition, since it's genome-wide, it doesn't flag a specific pathway. On the other hand, some of our older biomarkers like LDL cholesterol and blood pressure are predictive because they do flag a specific pathology that we know can be targeted and treated to improve cardiovascular risk. And so one of the reasons I mentioned that example is going back to the original soluble biomarker CRP, for which which has generated a lot of debate over its prognostic value, as I've alluded to earlier. But really, one of the more exciting aspects of any inflammatory biomarker is the potential, at least, that it could be predictive, that it could flag individuals with higher levels of inflammation who may benefit from therapy. And two trials done by Paul Ritker's group illustrate this. And so the CANTA, and these are both trials in largely secondary prevention, so not exactly the topic of this talk, but I think illustrative nonetheless. So in the CANTOS trial, therapy with an IL-1 beta blocker in individuals with high CRP levels were associated with a reduction in cardiovascular event. And in that trial, therapy reduced levels of CRP at the same time. Whereas in CERT, a trial of low-dose methotrexate, there was no reduction in therapy, even though individuals were treated with an anti-inflammatory immunoactive drug. Yet in that trial, there was also no change in CRP levels, suggesting at least a possibility that the CRP levels flagged individuals who were more likely to benefit from therapy. And one reason for the relevance of this, even though some of these therapies aren't used, actually neither of the therapies is used for cardiovascular disease, is that there are a number of therapies that target the same pathway, including common therapies like colchicine. And so again, one of the reasons that CRP, even if its predictive or prognostic value may not be enormous, that there's still interest in measuring and pursuing this pathway. So on the topic of finding new biomarkers, this is a result of a simulation that we did over a decade ago using Framingham data to illustrate really a common sense point, which is that when you're looking at biomarkers, especially if you're looking at combining biomarkers, the thing that is most likely to add to the C statistic are biomarkers that are not correlated to the biomarkers that you already have. And so these three curves really illustrate the scenario of groups of biomarkers with an average pairwise correlation that's moderate at 0.4 versus groups of biomarkers that have a low pairwise correlation of 0.05, showing that the low correlated biomarkers are associated with a much larger increase in predictive value in C statistic. And I show this because this is really the rationale for using omics technologies, the relatively unbiased technologies to find biomarkers, because almost by definition, if we look at biomarkers and pathways that we already know, for instance, let's say we're studying more inflammatory biomarkers, since they're correlated with biomarkers that we already have, like CRP, the likelihood that they're going to add to our predictive value or prognostic value is actually relatively low. And so that's the reason for using methods like proteomics, metabolomics, genomics to find new biomarkers. And these are studies that I've done now for several decades with Rob Gersten one of my longtime collaborators in Boston, to apply these methods to epidemiologic studies, types of studies that are done now in really every epidemiologic cohort in the world. I want to talk briefly about proteomics before I switch to the last topic of the talk, because it is probably the area of most active interest in the search for new biomarkers. The challenge of proteomics is really an analytic challenge. There are literally millions of circulating proteins and peptides in the blood. They include some of the most commonly used biomarkers in clinical practice. Those are shown in this graph in the yellow dots. The challenge is that these millions of peptides and proteins in the blood cover an enormous dynamic range of concentrations, from very, very scarce to very abundant, like albumin and transferrin and other transport proteins. And part of the challenge is that most of the biomarkers, in fact, nearly all of the biomarkers that are used in clinical practice are at the lower end of the concentration range. And so it really is truly the needle in the haystack, how to find useful clinical biomarkers out of the millions and millions of proteins in the blood covering this expansive dynamic range. And it's one of the reasons that the traditional technologies like mass spec, at least to date, have been relatively unhelpful for studying human biospecimens, because again, the discriminatory and analytic characteristics of mass spec are such that very low concentration proteins are difficult to detect. And it's for that reason that many groups have started to look at other technologies to measure protein, including this platform, which is based on the use of DNA aptamers and has been commercialized by a company, SomaLogic. DNA aptamers are basically DNA molecules that have antibody-like specificity, so they function like antibodies, but because they're DNA, they can be read out using common genotyping type technologies, and so you can measure literally thousands of them on a chip. Peter Gans and his group at UCSF has done some of the earliest studies using this platform to look at cardiovascular disease. These are data from the heart and soul cohort showing that a group of 9 proteins using this platform discriminated individuals who developed future cardiovascular disease from those who didn't. The challenge is that some of these data have been difficult to reproduce in other types of cohorts. And so we used the same platform in the Framingham data and found a completely different set of 6 proteins that were associated with risk in Framingham. Now, they're different cohorts with different levels of risk. And so it doesn't mean that either of the findings is incorrect, but it does illustrate some of the challenges in the early days of trying to interpret data from multiple studies, even using the same analyzing platform. So some of the challenges of proteomic biodiscovery are shown here. Fundamentally, you need huge sample sizes because of the multiple tests that are being done on the samples. Replication as a result is really critical. But you're doing these studies using biospecimens that have been collected over decades and are depletable. And so you don't have an endless supply of biospecimens in order to do these studies. And at present, the individual measurements are really quite costly. To do a assay on a single individual, a single specimen, still costs in the hundreds and sometimes thousands of dollars. And so the ability to do these at the scale that is being done for genomic studies, for instance, is almost prohibitive. There have been a couple of different strategies used to try to overcome some of these challenges. One of them has been really pioneered by Dan Roden and colleagues at Vanderbilt, which is really to use discarded clinical samples. Every day in all of our studies, we throw out samples from patients. And so about a decade ago, Dan came up with the idea of collecting these samples at Vanderbilt and saving them. The ability to save them was enabled by a consent that's administered to every patient who is admitted to Vanderbilt, in which they consent to the donation of their residual blood or tissue samples for de-identification and use for clinical research. And so a robotic system was set up in the clinical laboratories at Vanderbilt to collect the discarded samples. And then an EHR-based algorithm was used to de-identify the clinical data and combine it with the sample. And the primary purpose of this was to create a DNA biobank, which is called BioView, and which contains about 250,000 unique DNA samples. And so one of the ways that BioView can be leveraged, even though it's fundamentally a DNA biobank, is shown in this slide. And so this again is Jonathan Mosley, one of my collaborators at Vanderbilt. And we worked on this idea of implementing virtual proteomics, which is what if you could use the DNA and basically predict people's protein levels. And the way you would do that is you would take a smaller study like Framingham shown on the left, in which about 2,000 individuals have both plasma measurements using the SomaLogic platform and DNA specimens. And in that small cohort, because we have both measurements in that cohort, you can basically create a polygenic risk score for each protein, a genetic predictor for protein levels, but for each individual proteins. So in this case, there were over 1,000 proteins analyzed. You would then take that data and apply it to the cohort, the large biobank in which you only have DNA. And you would basically use the DNA to basically reverse engineer or impute levels of the proteins in the cohort. So even though you haven't directly measured the proteins in the DNA cohort, you can use the genetics to predict protein levels in the cohort as if they had been measured. And the advantage of the biobank cohort is because it's linked to an electronic medical record, you can relate it to thousands of clinical diagnoses. You're not restricted to diagnoses that you have adjudicated. And so using an approach like this, we conducted a proof of concept study in BioView and then applied it to a prospective data set in which we identified 6 putative biomarkers for atherosclerotic coronary or peripheral artery disease. The results on the left are what we got from the virtual experiment using the EHR and the DNA biobank. And the results on the right are results in a prospective epidemiologic cohort in Sweden, where these 6 biomarkers are actually directly measured. And as you can see, there is correlation between the results. It's far from perfect, as you would expect, given the methodology, but it illustrates, I think, at least a proof of concept that you can use a virtual approach to narrow down the universe of proteins that you're interested in, and then go to a cohort and directly measure them to see whether these signals are robust or not. So I want to end the talk in the last 10 or 15 minutes or so and turn to therapies and management. Because at the end of the day, even if we get better at predicting who's going to have cardiovascular events, we still need to think about the best way of applying therapies to manage them. And one of the reasons I want to focus on pharmacologic therapies in this section of the talk is because we all know that lifestyle measures are challenging. They remain the foundation for primary prevention, but dietary guidelines and exercise guidelines are challenging not just for patients to adhere to, but really challenging as well for physicians to figure out how to incorporate counseling on lifestyle measures into the daily clinical practice. One data-driven illustration of this is from the Simple 7 criteria from the AHA, which, as you all know, are a group of lifestyle criteria that predict cardiovascular risk. If you look at the individuals who meet all of life's Simple 7, that proportion is enormously low. It's low really everywhere in the country, but it's particularly low in some areas of the country, including where I spent, over the last decade practicing medicine. And so it's difficult to count on lifestyle and lifestyle measures alone to substantially reduce the burden of cardiovascular disease risk. The challenge, though, is that while we now have really thoughtful clinical guidelines on pharmacologic reduction of risk, they're actually quite complex. And so the guidelines on the left are the current ACC/AHA guidelines for cholesterol therapies. And the guidelines on the right are the analogous guidelines for blood pressure therapy. And the purpose of these flowcharts is obviously not to go through them, but just to illustrate that in common clinical practice, especially for primary care physicians, it can be challenging to implement these guidelines in busy clinical practice. that may be one reason that when you look at the data, that the uptake of even well-proven cardiovascular drugs like statins and primary prevention is relatively low. And so this is a series of studies done by Anne-Marie Navarre and Eric Peterson, both of whom were at Duke and the DCRI at the time that the studies were done, but both of whom are currently at UT Southwestern. And collectively, the studies that they and others have done have shown that about half of US adults now have some clinical indication for a statin under the current ACC/AHA guidelines. But at least 30 to 50% of those individuals aren't currently on cholesterol medications. And if you look deeper and look at the results of surveys, it appears that the most common reason they're not on these medications is not because of adherence difficulties, but because physicians didn't prescribe the medications in the first place. And so again, illustrating the multifactorial nature of this challenge. The picture is really the same for blood pressure. And so in the NHANES data set, control and recognition of blood pressure has been studied for over decades. And some of the time series data are shown here, illustrating that if you look at how well blood pressure is controlled among all adults with hypertension, all adults with known hypertension, fewer than half of those adults have controlled blood pressure. What's even more striking to me is that even if you look among adults with hypertension who are on an antihypertensive therapy, only about 60% of those individuals have their blood pressure adequately controlled. So even when they're on the medication, their blood pressure is not at the target levels. There are a number of reasons for this, obviously. One of the contributing factors almost certainly is the impact on adherence of polypharmacy. And so as patients get older and accumulate comorbidities, they often end up on multiple medications and they require frequent visits to the physician for titration. As a result, staying on these regimens can be difficult. And any of the registries that have looked at the use of cardiovascular therapies across the world have really come up with a similar conclusion, which is that long-term adherence to cardiovascular regimens is roughly around 50% and lower in some countries. And so what can be done about this? There have been a large number of studies done to try to understand what can be developed to improve both prescription and adherence to cardiovascular medications. I want to focus on two concepts to end this talk. And I sort of bucket these using sort of more commonly understandable in the sort of the general medical practice terms. I'll call them vitamin-like strategies in vaccine or injectable strategies to improve adherence and prescription. The first is the vitamin-like strategy. And I think the prototypical example of this strategy in cardiovascular disease is the polypill. The idea that if you combine the statin plus several blood pressure medications into one easy to take pill, a pill that can be taken once a day, is relatively inexpensive. The blood pressure medications that are included in this pill are given in half to quarter doses so that the multiple medication can be combined safely. And because they're all generic pills, they can be administered at relatively low cost. The idea that this concept would work and that this pill could be applied to broad populations with relatively little testing and titration relates to several factors, several concepts. One is the idea that the relative risk with statins is actually relatively constant across a broad range of LDL levels. These are data from the heart prediction study, but they've been duplicated in a number of other settings, showing that no matter what your baseline LDL cholesterol level is, or your baseline total cholesterol level, that the relative risk reduction from statins is about the same. And so while it can be useful to get a baseline LDL cholesterol, the LDL cholesterol level actually doesn't necessarily dictate whether someone will benefit from a statin or not. The second concept to point out related to blood pressure therapies is that the side effects of blood pressure medications are typically dose related. That's true of almost any class of blood pressure medication, including the ones shown in this slide. And so these are data from a meta-analysis showing that either for thiazides or calcium channel blockers, as you increase the dose of the medication shown along the horizontal axis, the rate of the proportion of individuals with some side effect goes up. Not terribly surprising. But it emphasizes that if one of your goals of blood pressure therapy is to minimize the adverse effects, then maybe better off to start with half doses or even quarter doses and combine multiple of these medications at low doses to get the efficacy that you need, but keep them at the low doses to minimize the side effects. This concept has actually been formally tested in randomized trials. This is one of the most recent ones, the Quartet trial published in The Lancet last year, showing that individuals who were randomized to monotherapy with an ARB at full dose versus quadruple therapy with 4 medications at quarter doses, that those on the quad pill ended up with significantly lower systolic blood pressures compared to those on the monotherapy, with no difference in the rate of side effects. Shown on the right, I think, is an interesting observation. So this is at a year, a diagram, a histogram showing that in the intervention group at the end of a year, 80% of them were still on the quad pill alone, but about 20% of them were on the quad pill with some add-on therapy. And that's a useful thing to emphasize, which is that although these low-dose fixed combination therapies aren't particularly titratable because the doses of the blood pressure pills in the combination therapy can't be altered, it doesn't mean that you can't add therapy onto that. And so as shown from this trial, at least a fifth of individuals ended up on some additional therapy on top of that. In the control arm, about 57% of individuals ended up on the monotherapy alone, and about 40% of individuals ended up on the monotherapy plus some other therapy. And so, what are the data with polypills? We only recently have been getting outcomes data from clinical trials almost entirely in the non-US setting. And so this is a meta-analysis of 3 large randomized trials that have been published in the last several years, looking at a fixed dose combination therapy with a polypill versus control, showing really a consistent relative risk reduction for cardiovascular events across a number of subgroups. As I mentioned, none of the currently available trial data are based in the United States, which has always been a little bit of a limitation when interpreting whether these data could be applied broadly in our country. Because of this, some number of years ago, Dan Munoz and I conducted a small study in the Southern Community Cohort, which is an epidemiologic cohort in the Southern United States. And we took a subset of individuals from this cohort who were enrolled in a primary care health center in Mobile, Alabama. The characteristics of patients attending the center were they were predominantly African American, and 3/4 had an income that put them well below the US poverty line. One of the reasons we chose the Southern Community Cohort in Mobile, Alabama, in particular, is that this is an area of the country with the highest, some of the highest rates of death from heart disease and cardiovascular disease. And so we took 300 individuals from this cohort and we randomized them for a year to a polypill versus conventional care. And what we find after a year is that use of the polypill was associated with significant reductions in blood pressure and cholesterol compared with those randomized to usual care. And one of the striking findings to us was that, that the adherence to this pill was actually quite high. At 1 year follow-up, 91% of individuals were still attending visits to the study. And by pill counts, 86% of individuals were still taking the pill in the active control arm. So again, we felt that this was useful both because of the population study, the fact that it was conducted in the US, and potentially an illustration that that the polypill is at least a viable strategy that warrants further investigation in this country. Just want to end with the idea of vaccine-like strategies, because the way people take preventive therapies in this country for things not just cardiovascular disease is not just taking vitamins, but they also have broadly accepted the use of vaccines intermittently. As a background for this idea, I just want to highlight some of the work that really started at UT Southwestern. This hallway here in the building right next to where my office is located is where the labs of Mike Brown, Joe Goldstein, and Helen Hobbs are, and really as a result of their work has led to many of the fundamental observations that have led to many of the cholesterol therapies that we use today. Helen is particularly known for her work elucidating the pathway by which PCSK9 can interfere with or can affect the degradation of the LDL receptor and impact LDL levels. And some of the original human work done by Dr. Hobbs and her collaborators was in the Dallas Heart Study. And in that study, she and others showed that individuals with a loss of function mutation in PCSK9 had dramatically lower LDL cholesterol levels, as shown here on the left, compared to those individuals without the mutation. And strikingly, those individuals with the mutation, with the low LDL cholesterol levels, virtually had non-existent coronary artery disease. There was really a striking difference in the experience with cardiovascular risk, according to Carriage, of this relatively uncommon genetic variant. And so that led to the concept that PCSK9 could be a viable and safe target to target LDL cholesterols. And that has led to currently 3 FDA-approved therapies shown on this slide to lower LDL cholesterol levels. These are currently injectable therapies. And so either with monoclonal antibodies, as shown here at the top, or with the recently improved silencing RNA inclisiran, which is an injectable that can be taken just 1 or 2 times a year and results in dramatic reductions in LDL cholesterol. There's a company in Massachusetts led by Dr. Kathrayson, who I mentioned earlier, which is really exploring this concept even further, which is can there be an injectable approach that really results in a lifetime of LDL reduction using CRISPR gene editing technology. And they have some very interesting data from primates currently. And so I mentioned this, of course, to emphasize the potential for these injectable therapies given only once or twice a year to cause long-lasting reductions in LDL cholesterol. Again, similar to how we currently implement vaccines, for instance, for the flu. This concept has been sufficiently exciting that in the UK, there's now a contract between the National Health Service and the maker of one of these medications, Novartis, to purchase 300 doses, or actually doses for 300,000 patients with high cholesterol and a history of cardiovascular disease to make this injectable drug widely available to this group of patients for long-term lowering of LDL cholesterol level. And I found this quote particularly interesting from Dr. Samani, who's the medical director of the British Heart Foundation, who really, sort of gives a vision for the future, which is that in the future, a much wider group of people may be eligible for taking these drugs to prevent a heart attack or stroke. And so, again, emphasizing the potential application of therapies like this, even at a population level. So with that, I just want to present a few slides to sum up. The first is to consider these last set of approaches that I talked about, the polypill and injectable approaches, and ask the question, are these approaches counter to precision medicine, which I started the talk with? And some of the ways in which they might be viewed as anti-precision medicine is that they're really targeting biological products like LDL cholesterol that are universal to cardiovascular disease. That they typically or may involve less monitoring or titration because they're given either infrequently in the case of the injectables, or they don't require titration in the case of the polypill. And so for any given patient, these regimens may feel less precise. On the other hand, they may be more sustainable. They may be easier to adhere to over long periods of time. I would also emphasize that you can combine these broad strategies with add-on therapies, as I mentioned, the Quartet trial. And there are a lot of examples like this from fields outside of cardiology. As one, I would point out the Hep C drugs. We typically treat hepatitis C with combination therapies. And although nowadays we can extensively genotype or precisely genotype the Hep C subvariant that is contributing to an individual patient's disease, the choice of combination therapy is really almost unrelated to the genotype that we identify. And so again, the idea that this can be used in other disease categories is potentially attractive. And so will the future of cardiovascular prevention look more precise or less precise? I would argue that there are still reasons to believe that increased precision in the future is something that we may see. I do think eventually it will be possible to identify a larger number of predictive biomarkers and genetic profiles that are associated with cardiovascular disease. I think that use of these identification therapies is going to be relevant. Use of these identification methods is going to be relevant when we're looking at therapies that may have more side effects or more cost. And as an example, I would point to some of the immune active therapies that I mentioned on the slide with the trials done by Dr. Ricker and colleagues. I also think that leveraging data from multiple sources and thinking of ways that we can routinely collect patient specimens, especially specimens that would have been thrown out anyways, are two of the things that we can do to continue to advance this field. On the other hand, I think there are some ways that the future of cardiovascular prevention may look less precise. I think we may eventually, for some patients, focus on delivery methods that reduce complexity for both patients and their physicians. I think these methods may be particularly relevant for therapies with fewer side effects and cost. And an example of that, of course, would be statin therapies. With therapies that are relatively inexpensive and relatively easy to take, it may not be necessary to bring to bear complex mechanisms of testing and profiling. And I think that the evidence is building that initial combination therapy may be appropriate for potentially broad groups of patients. And so I'll end there. I really do appreciate the opportunity to join you this morning. And it's really a pleasure to reconnect with old colleagues and look forward to seeing many of you again in the future.
Thanks, Dr. Wang. And I appreciate the great doc that went through both biomarkers for precision diagnosis, but the strategy for therapeutics. While I wait for questions, I do want to sort of pose a question myself. So, in an era where the goal is to go, and that's obviously the topic of your talk as well. How do we incorporate more of the biomarker-based strategies, especially when proteomic profiling and risk would come in a more public health-based environment? So when our focus is expanding access and a limited, ability to deliver care to a vast number of, especially individuals who, we've not reached yet, even with the, care, and PolyPill helps with that. How do we incorporate the biomarker-based precision care solutions in that care model?
Yeah, I think that's a very important question. And I think as your question implies, we really shouldn't lose the forest for the trees, or I guess to use another expression, shouldn't let perfect be the enemy of the good. And what I mean by that is, I think really most of these things that I mentioned in the first part of the talk are not ready for prime time. Polygenic risk scores, measurement of new soluble biomarkers, nor should we necessarily focus on them for most patients. I think what the data have shown is that for the majority of patients that we see in clinical practice, conventional risk factors do a good enough job of putting patients into buckets. I think where we might think of using some of these biomarkers, especially the ones that are more easily available like CRP, are for patients for whom we're really on the fence about a therapy, or we think maybe demonstrating something like CAC would either motivate us or motivate the patient to take and stick to a statin regimen or really pay attention to the blood pressure. So really the patients, for whom the test will really cause an alteration in therapy. But again, routine use of these for most patients probably is not something that we either should or need to do right now.
Great. Thank you. I see Dr. Churchill's hands up.
Tommy, thanks for the hours. Great to see you once again. So I thought about your first two slides and the examples of the three individuals and our ability to predict their cardiovascular events. And thinking through the last 50 minutes, that seems to be two different questions, right? Because you're talking about looking from a population perspective, the life of an individual and their overall chance of actually having the progression of an acute event, as opposed to trying to predict an event for an individual within the 30 or 60 days when you first see them within the clinic. Thoughts about, is there a pathway that we're actually evaluating to actually do that particular work? Someone you're seeing, like a Kyle, who actually may have some risk factor profile in their past, that we can actually do a test or do an assessment to get a better evaluation or a better knowledge of whether they're actually at risk within a very sensitive time frame?
That's a fantastic question. It actually brings to mind an experience that I've had working with Ben Levine and James Lamos here at UT Southwestern with another very sort of specific risk-based question over a discrete time frame, and that's because of Ben's work with NASA. And so NASA had contracted Ben to basically say, how do we predict risk in people who are going on a mission to Mars? You know, a mission that'll take a couple of years. But the last thing we want to do is have them have an MI or even AFib or some cardiovascular event in space, because there's nothing we can do for them. The short answer, as you might guess, is that it's tough. We did a number of studies applying many of the tools that I've shown to say, can we predict 2-year risk or 3-year risk over very discrete timeframes? And the short answer is, none of the tools work particularly better for that than for the longer term timeframes. Again, it just, based on what I've read and reviewed and been involved in, if I had to pick one test for someone going to Mars, I'd probably do a CAT scan. And that's just because of the data that we have from other things. But your question is a good one, and we don't have it. And of course, as even with the CAT scan, we're looking for plaque, but we have no idea whether that plaque is vulnerable, prone to rupture in the short term. I mean, all of the questions that as cardiologists we encounter every day, and our tools, unfortunately, just aren't that good yet.
I have Dr. Bender next, and then there's I'll ask Erica Spatz to jump in.
Ami, that was a great talk, and congratulations on all your work. I wanted to revisit the virtual proteomics that you discussed, partly because I don't completely understand it. I mean, I like the idea of it, but obviously knowing genetic sequences doesn't tell you about the activity of promoters and enhancers and epigenetic modifications, and in particular post-transcriptional regulators, including microRNAs. And so that's a little bit of a segue into your area of microRNAs as biomarkers. You didn't mention that, and I think that's potentially very promising. So I guess that's sort of a mixed comment and question, if you could address that a bit.
No, you're absolutely right, Jeff. I appreciate your bringing that out. And the way I think of virtual proteomics, because you're right, it suffers from the same problem that DNA. You're not really predicting any interaction of this machinery with the environment or other exposures that certainly contribute to your risk over the lifetime. I think the way I view it is you're basically, it's something for identifying some subset of biomarkers that may be or a predisposition that may be intrinsic. But it may be only 10% of the useful biomarkers could actually be identified by this approach because because it is so insensitive to the environmental factors. The argument is that we probably only we probably only have 10 or 15 biomarkers, if you don't include the polygenic risk score, that have been proven to be useful. And so even taking a little subset of the useful ones, at least as a starting place. The other thing that I would say, which is a little bit more speculative, is that if a biomarker is useful in this setting, it doesn't mean that it's not also useful over the lifetime when it goes up and down. It's in other words that it could be useful in both respects, but we're only looking at one dimension of it, which is basically the intrinsic capacity that biomarker. Does that make sense?
Yeah, thank you.
Dr. Erica Spatz, who has a comment in the chat. Erica, do you want to just unmute and ask yourself?
Sure. Thanks so much for a great talk. I got to spend some time with Meet Kara and Ben Levine at ACC, so I feel like I'm getting a full dose of UT Southwestern work. This is terrific. I was wondering if you could talk more about your trial in Alabama with the poly pill and what some of the experiences were of patients. How far are we from seeing poly pills appear in the pharmacy? And are there any unintended consequences that we need to think about, especially as as the data have emerged in low and middle income countries, and now, an amazing study that you did in Alabama in low socioeconomic communities, which I think holds a lot of water for really moving population health. But I wonder if you could talk if there's any unintended consequences that we need to be mindful of as we scale the polypill.
Yeah, that's an outstanding question, and I think an important one. I guess to address the first part of the question, it was a really valuable experience for us. I personally had never done a trial in that setting, and you could spend a whole hour on the sort of really valuable lessons from studying that population, but also understanding what I think are real opportunities to improve care in populations in the community. But to answer your question, I absolutely, for me, I try to think of myself as being in equipoise about the polypill. I think one of the purposes of the trial was really to demonstrate that this therapy or approach to therapies was worth a broader scale study. We never really had the illusion that studying 300 people in a single community health center was going to help us know whether this could be expanded at a large scale. And there could be unintended consequences. There's certainly concerns about, basically trying medicalization of preventive practices. There are concerns that maybe if people take a pill that they think is helping cardiovascular disease, that it will demotivate them for doing other things that will reduce risk. Although I would say that the evidence that we have from other fields that taking prophylactic or preventive therapies causes them to do more risky behaviors is actually relatively tenuous. But I think all of these things deserve to be understood and studied. And so we, again, really embarked on this trial really as a way of hopefully motivating larger scale study of polypill-like approaches in this country. The challenge, though, to get to the final part of your question is that it's difficult to get people to sponsor trials like this, because by definition, the polypill is not something that any individual pharmaceutical company is highly motivated to support or get behind, because these are all generic drugs. And so this would happen from some sort of federally funded effort, which is a challenging proposition.
Eric, do you want to go next?
Well, first, Tommy, thank you for a wonderful talk and for joining us. We will have you here in person.
From you in a while.
Yeah,
if someone needs to mute themselves.
Mess up work with a personal phone.
Yeah,
That's
Irma,
like
could you mute yourself, please? And so thank you for that. And I guess my question relates to a beautiful theme that you developed through your talk, which is this differentiation between prognosis and predictive capacity of anything we do, really. And I kind of want to push you a little bit on that and kind of talk more about the kind of third kind of component of that chair, which is actionable, right? And so, certainly we want biomarkers or anything to be prognostic, hopefully predictive, and then actionable. And as we think about moving some of these biomarkers into general care, have you thought through the regulatory implications as it relates to how we establish these hopefully predictive and actionable biomarkers which intersect with either treatments or strategies of treatment that will be need to be kind of evaluated in a regulated environment by the FDA and others? And have you thought about how we get to that next step?
Yeah, that's a fantastic question. Again, another one that could take up a whole hour. The short answer is yes, me, but also many other people, of course, have thought about this. And the fundamental challenge, which you're getting at, of course, is, once you have a biomarker and you think it might be predictive and predict response to therapy, what types of studies do you need to get it approved? Do you need to do a biomarker randomized trial? Basically, do you need to randomize large populations to getting that biomarker measured or not and see what happens downstream? As we know from the cancer screening literature, those are massive trials, very difficult to do. Or is it sufficient to take an existing randomized trial and go back and post hoc measure the biomarker level and say, well, lo and behold, people with a certain biomarker level benefited from this study or not? That would be much easier to do. But again, many would argue that doesn't meet the threshold for a prospective study that would really warrant wide-scale use of a test. And I would say, in short, that is still not resolved. I think that is still something that is being debated. Ideally, you would do the prospective biomarker trial, a strategy trial of measuring the biomarker or not. But again, you of all people would, I think, certainly understand and appreciate how challenging those trials are to do, and how many years and years it would take to do those trials. And so it's a fantastic question. One would hope that there was some sort of compromise approaches so that we wouldn't have to wait 2 decades after we find the biomarker to actually get it into wide-scale use, but that there could be a compromise and an agreement on some sort of intermediate level of trial data that would be sufficient to get something into use.
Well, Tommy, thanks. I mean, I look forward to working with you and others around this. I mean, I think one of the potential opportunities is to ask more of our governmental agencies to help us utilize the funds that are being spent maybe unwisely on certain strategies to push the envelope on some of these kind of strategy type trials using more precision approaches. So hope we can move that forward.
That's great. Yeah, that's fantastic. I totally agree.
No, I think with that, we were like 8 minutes off after. So I appreciate the time that you spent with us today and all the excellent questions and discussion. And I mean, as everybody here, I'm sure says, that we would love to have you in person sometime in the future so we can have a longer conversation and our fellows can get an opportunity to connect as well. Thanks so much.
Great. Thanks so much, everyone. Really appreciate it.
Bye.